Hello, all you amazing women, and welcome to How to Feel Like a Midlife Goddess. With me, Amanda Ryder, nutritionist and author. Now, I call this podcast How to Feel Like a Midlife Goddess because, let's face it, so many of us don't feel like shining in midlife. We can be grappling with physical and psychological symptoms, which can lead to a real loss of confidence, and it can feel like you're really losing your identity. However, I believe it's possible for us all to feel good at this time of our lives. So each week, I'm going to be sharing with you my best nutrition and lifestyle advice, as well as interviewing expert speakers. And week by week, together, we will build upon a foundation of healthy, sustainable habits that will really benefit us and make all the difference to how we feel. So stay tuned, because this is your recipe for thriving at midlife and bringing out your inner goddess. This week, we are joined by Dr. Susannah Unsworth, who is the founder of Cambridge Women's Health. Dr. Unsworth began her medical journey at Pembroke College in Cambridge, graduating from the University of Cambridge School of Clinical Medicine in 2005. And in 2010, she became a member of the Royal College of General Practitioners and served as a GP in Cambridgeshire and Suffolk. She now works as a specialty doctor in the breast clinic at Addenbrooke's Hospital here in Cambridge, and has gained diplomas from the Royal College of Obstetricians and Gynecologists. She also holds a postgraduate diploma in community gynecology from the University of Bradford and an advanced certificate in menopause care from the FSRH. Please stay with me, guys. I know this is a long intro, but anyway, in addition, Dr. Unsworth has full registration on the British Menopause Society and to provide women with high quality advice and space in the menopause sort of area. So today we're going to be talking all things midlife and HRT. So yeah, very, very impressive credentials. Well, thank you for taking the time to come on the show.
It's okay.
And yeah, tell us a little bit more about you. So obviously I've given the kind of, the blurb on your credentials, which all sounds, pretty impressive. But yeah, you can tell us about your clinic and how you got started.
Sure. Yeah. So as you said, I come from Yorkshire originally. So, but yeah, I've lived in Cambridge now for quite a long time. So I feel my accent has probably been a bit diluted. But yeah, I came to university in 1999 in Cambridge and qualified in 2005. And then I did quite a few jobs in the Eastern region before I decided I wanted to work in general practice, because I really wanted to do sort of a more community-based medicine rather than necessarily acute things in the hospital. And then as a GP, and being a female GP, I used to see lots and lots of women, and it really made me sort of realise that was the area of medicine I was most interested in, and that's what led me down the kind of route that I've taken, focusing on women's health more. So whilst I was working as a GP, I did do quite a lot of extra training, most of which sort of in my own time, because it was what I was interested in. As I was doing more and more training, it sort of made me feel more and more like this was the direction I wanted to take things. So I eventually made the decision that general practice was probably not where I wanted to stay. I think it gave me a brilliant for kind of managing every single health problem under the sun, because that's what as GPs we have to be expected to do. But I think I really realised that I wanted to then start to focus more on women's health. So that's what led me down that route. And then as part of my training, I started doing quite a lot of menopause work and menopause training, and I realised that was an area I was particularly interested in. And up until recently, I would say that it's an area that sadly wasn't particularly well supported in medical training, but also just in sort of medical settings generally. And I think a lot of women probably recognise that menopause has been a bit overlooked for quite some time, but that is definitely changing. But yeah, so the opportunities arose for me to sort of move away from general practice, and a role came up in the breast unit at Addenbrooke's, and it's been really lovely working there because I've been able to kind of develop my menopause work a bit there, and particularly for supporting women who've had breast cancer. So that's kind of one of the key areas of menopause care that I do work in. The different sort of roles there. So one of the roles I do is for women who've had a problem with their breast. They've found a lump, they've noticed something that's different, they've had some funny discharge or something that they're worried about. about. Most of the time they'll go to their GP for that, and then their GP will refer us to refer them up to us at the breast unit. So one of my jobs there is I do the assessments of women who've had a new problem, and so I'm often the first person that they would see. There's quite a lot of us that do that same role there, but yeah, we'd see them and then arrange whatever investigations they might need for us to check out that problem. And just to sort of reassure people, most of the time it's nothing to worry about, but it's really important if you do find something wrong that you do go and get it checked out. But the other side of my role there, though, is focusing on women who have had a cancer diagnosis, and we support women beyond that within the breast unit. So we follow women up generally for 5 years after their diagnosis. And one of the things that I found particularly that women were struggling with was menopausal symptoms after breast cancer. So either because they're naturally going through menopause, which is quite common with the age group that generally do have a diagnosis, but also potentially as a consequence of the treatments that they're having. And so as part of my role there, I've kind of developed the clinic a bit more to support women with these problems. And so I have a clinic now specifically for that as well. So I do a bit of a combination of things in the breast unit.
Well, firstly, I hear so many good things about the Cambridge Breast Clinic. You know, a lot of women I see too have been there and they're like, oh my goodness, they are excellent. You know, they make you feel at home, at ease, you know, very reassuring. So yeah, well done for that. But yeah, when women have had a lump or they have had breast cancer or they're deemed as high risk, then they're usually told, aren't they, not to take HRT.
Yeah, so it's always a bit of a tricky one. I think if somebody finds a lump and they're on HRT, my usual advice is, because we're going to see you really, really quickly, I don't feel there's any reason to just suddenly stop it there and then. You know, most of the time we'll see women within about 2 weeks of them being referred, thereabouts, and 90% of the time it's nothing sinister. So I always find it a bit frustrating when people have been told to stop their HRT, because actually in that short space of time, worst case scenario, if it was a breast cancer, that isn't going to make a huge difference. But for some women, you know, abruptly stopping their HRT could actually be really problematic for them. I guess the problem arises when women have had a diagnosis of breast cancer. So in that situation, then we would recommend that they discontinue it. Now, we usually do say they can do that over a period maybe of a few weeks if they want to. Some women just want to stop it straight away once they've had that diagnosis, but I would often say actually it's probably a bit nicer to just gradually reduce it, maybe over 2 to 3 weeks. And then there'll be lots of things that happen immediately after that diagnosis. Once they've kind of reached that point and they've come out the other side, I then usually see them, if there's a problem with their menopausal issues, would see them in my clinic, and we talk about the different options to help support them with the symptoms. So the vast majority of the time, we would look at using non-hormonal options, because the difficulty is the evidence of what the risk is in terms of HRT after breast cancer is very complex, and that there isn't a huge amount of data available. Frustratingly, 2 of the big studies that really were looking at this question had to stop early because they appeared to show an increased risk, and it just makes it very, very difficult for us to say with certainty to someone what the risk is. So our standard approach is actually we would deem it to be contraindicated, so not recommended, and we would definitely look at alternative options. And there are lots of alternative options that we can consider. So Maggie's is a charity that they have a branch on site in Cambridge, but they have branches all over the UK, and they offer lots of support for women around menopause who've had any cancer diagnosis actually, but particularly with breast cancer. And there are lots of non-medical interventions that can be really helpful. So things like cognitive behavioural therapy and acupuncture, both of these actually have good evidence to support them. And I've got lots of women who found those to be really helpful. So I often direct women to those sort of things. We do talk about other medication options that we could consider as well if somebody is really struggling, particularly with hot flushes. Seems to be kind of one of the big symptoms that a lot of women will struggle with. And there are a few medication options that we can try that are not hormonal. There's a new medication that has recently been released, which is hopefully going to be something that we might be able to use even more with women who've had breast cancer. So there are lots of things we can try. But sometimes some women, if they're suffering severely and we've tried everything else and they're still really struggling, then I feel it's appropriate for us to, think about the option of considering hormone replacement therapy. Now, I can't say that it's a safe choice because we don't actually know whether it is or it isn't. The data is really quite mixed. But sometimes it's about weighing up that risk and benefit balance. And if somebody is suffering severely and they really feel their life is hugely negatively impacted by their symptoms, they may make that choice to say, well, I'm accepting that there may be a risk in me doing this, but I can't keep going the way I am. And I have women like that. And I feel it's important that they at least have that option of being able to do that if that's what they choose to do, providing they understand.
Yeah, and having to, being able to make that decision with a healthcare practitioner is, empowering.
It takes a long time for us to kind of walk it through, and sometimes we'll talk it through and then they'll change their mind. But I think it's just about having that option. And I don't think we, as doctors, we should ever really be in this position where we tell someone you can or can't have something if it could help them. Obviously, we've got to be sensible and recognise that there may be risks involved, but I think we have to give people the opportunity to make that decision. I've had a few women that have chosen to take it and really been grateful for that chance, and most of the time they've been really actually happy with that choice because it's made a huge difference to their quality of life. And then I've had other women where we'll talk it through and they say, actually no, I don't want to take that risk. I'm willing to accept the symptoms I'm experiencing, and we do as best we can to manage them as much as possible.
I mean, breast cancer to most of us just seems so scary. And it's the diagnosis that women fear the most. But, it's kind of like, the number one killer in women over 50, I think, is neurodegenerative diseases, isn't it? Like Alzheimer's and dementia. And then you've got heart disease. And then I think you've got lung cancer and then breast cancer after that, so the numbers are quite significantly lower, aren't they?
I think because the treatments of breast cancer have improved dramatically over the last, 40 years or so. And so for a lot of women, yes, it is a really emotive kind of diagnosis to have. But for a lot of women, it's actually really quite treatable. And so I think that is important to stress that a lot of women do really well after a diagnosis. Now, obviously, you mentioned about other causes of health problems in women, and it's true, kind of dementia, neurodegenerative conditions, cardiovascular disease, and osteoporosis as well. Actually, the consequences of that are actually more significant. Women die from those conditions in much bigger numbers than they do from breast cancer. And I think sometimes it's just about trying to put it into perspective. Obviously, nobody wants to have that diagnosis, but I think it is sensible to put it into a bit of perspective with other things that maybe a lot of women are putting themselves at risk of without even necessarily thinking about. So certain lifestyle choices and things are going to increase the risk of cardiovascular disease, but people don't often always worry so much about that.
No. And
the balance of it is a bit skewed, unfortunately.
Yeah, and I don't know if you see this in your clinic, but I certainly see it with the women that I work with, that people are coming in now, sort of over 45, and they've never had high cholesterol, and now suddenly, they're going through perimenopause, menopause, and their cholesterol's gone up. And we kind of lose that sort of elasticity, don't we, in the blood vessels, and our LDL goes up, which is sort of labelled the bad cholesterol, and the HDL goes down, and HRT can be really beneficial for that, can't it? It can be beneficial for lowering your risk of heart disease.
And there's increasing evidence about that, about the benefits of that, and particularly the sort of newer hormones that we tend to use now, so the more body identical estrogen and the body identical progesterone, has a much more positive effect on the cardiovascular system, and that can be hugely beneficial for some women. And when we start to lose those hormones naturally, that's when the cardiovascular risk factors start to increase, and we start to approach the situation in men who have a higher cardiovascular risk than women do naturally. And an HRT definitely has a role in that. I mean, at the moment, it's not recommended as being specifically for that as a preventative treatment, but I think it's one of the things that you have to weigh up in that kind of risk-benefit balance. You can't just take out one thing like the breast cancer risk and make your decision solely based on that. You have to put in all the other elements that it can benefit you, and then make that decision based on all of those things.
Yeah, because again, some women will be prescribed statins. instead of HRT. But if they go on HRT and their cholesterol comes down, they wouldn't need the statins.
Yeah, it's a tricky one.
And then maybe they'd get the other benefits to their making, their bones, and
Yeah,
they're
sure.
lowering their risk of other diseases.
Yeah, I think the difficult thing at the moment is HRT is not licensed as a treatment for any of these other things. The only thing in addition to treating menopausal symptoms that we can now use it for is to do with osteoporosis. So it has now been approved as a treatment for osteoporosis, but in a specific age group. So the women have to be under 60. So that's one step forward with that. So hopefully,
that's great. Yeah,
will be a really
progress.
Useful. Yeah, I guess the tricky thing is there isn't enough good data at the moment, I suppose, to sort of define HRT as a treatment for these things, and so at the moment that's not how we should be prescribing it. But there is evidence out there to show that there are these potential benefits. Now, it's maybe not good enough as an actual formal treatment if somebody has been diagnosed with a condition where they've got extremely high cholesterol. But if you've got someone who's having menopausal symptoms and they have a family history of cardiovascular disease, then it's something that it's worth them sort of thinking about the benefits that they may get in terms of their cardiovascular health, in addition to hopefully the good symptom relief from their menopausal symptoms that they will also get. So as much as not using it deliberately as what we call primary prevention treatment, but recognising that actually it probably will have a beneficial effect on those things. And I think that helps women guide their decision in taking it.
I totally agree. So, Susie, in your clinic, what would you say are, obviously people are coming to see you, presumably they're looking for help with their menopausal symptoms.
Yeah.
What are the most common symptoms you see?
So, hot flushing symptoms, night sweats, I think they probably are the most common thing. So it is estimated up to about 80% of women can experience some sort of what we call vasomotor symptoms. And they can vary in severity. Sometimes some people might just get occasional hot feelings. And then, I met a woman the other day who's literally having a hot flush every hour, day and night. And that is really severe. So I think that probably is the most common. But I think the things that maybe get a bit overlooked are maybe some of the more psychological symptoms that a lot of women do struggle with. So I often hear them say to me that they've noticed feeling very anxious, so anxiety over things that previously they wouldn't have troubled them. And their mood potentially being affected, feeling quite irritable and angry. And often women use this kind of phrase to say they don't recognise themselves because of the way they're sort of behaving, and their family have noticed it as well. And often it can create a bit of tension sometimes at home. And then sleep disturbance is probably one of the other big things that I do see. And that can be either a consequence of the waking up because they're having night sweats, but it can actually also be just a disturbance in their sleep pattern, not necessarily because they're waking up hot. And the problem is with sleep disturbance is that has a really negative knock-on effect the next day. And it's thought that possibly contributes to a lot of the kind of brain fog symptoms that is another sort of common issue. So that sort of verbal recall, memory issue, which can be really frustrating, particularly if you're at work and you can't find the word that you're looking for. And people often joke and try and gloss over it, but actually it can be really, really horrible and really interfere with kind of being able to sort of do your work, well, and can get quite frustrating. So I think they're probably the commonest things. And then one of the symptoms that I always ask women about is vaginal symptoms. I think sometimes that's not always a symptom people are openly talk to me about. So I always ask them directly. But that interestingly can become a problem quite early. We'd often thought that was maybe more about loss of estrogen, but interestingly, women in sort of perimenopause can start to develop those symptoms quite early. So I always like to ask about that.
And when you say vaginal problems, do you mean like dryness and pain?
Yeah, so combination of things. So dryness is really common, but sometimes women can notice a lot more discharge, and it's often likened to it when people say they've got a dry eye, but it waters a lot. If the tissues are quite dry, then sometimes any secretion that's produced just kind of comes away, and then you notice more of a discharge.
So okay. It's not because you're well lubricated.
Yeah, no, it can actually be almost the opposite.
Yeah.
And then it might lead to things like pain when you're having sex, but it might also just lead to pain generally. You know, we live in Cambridge and lots of people ride bikes. And a lot of patients say to me that they found it difficult sitting on a saddle because it's really uncomfortable. But it can also lead to more physical things like urinary tract infection problems and bladder irritation problems and things like that. So it can be really troubling. And so I always like to ask people about that, because actually there are lots of things that we can do to treat that are really effective.
I mean, I suffered with urinary tract infections from about 47. And, I would go cycling, like on a road bike, and maybe I just wouldn't drink quite enough. And then, boom, I'd get one.
Yeah.
And I'd always put it down to, I'd always have a reason, but I kept on getting them, I suddenly became really prone to them. And then as soon as I started hormone replacement therapy,
quite a lot of evidence to show the sort of the way in which the bladder cells are sort of stuck together is affected by estrogen. And once estrogen levels start to change, then that kind of the cells don't become as well stuck together. I don't know if that's a very technical term, but it allows bacteria to track into the bladder more easily. But also the opening of our bladder that we pee through, so the urethra, there's lots of estrogen receptors around that, and once the estrogen levels start to change, then that can become a little bit dysfunctional as well, and bacteria can track more easily up into the bladder as well that way. So there's lots of reasons why it can be strongly linked with urine.
I've also heard a theory that, the pH changes. You become, I can't remember if it's more alkaline or more acidic, but basically I think it's probably more alkaline, and then bugs can sort of take hold much more quickly.
And allows them to grow and then cause problems. So
and it's horrible. It's it's really, and then you start taking antibiotics.
Yeah, exactly.
And then that, you take a few rounds of antibiotics, and then you suddenly get something else wrong with you, or you have gut issues, and it's just, you're on this kind of vicious cycle. Not much fun.
I've definitely had women who've been having that, and they end up being put on antibiotics that they take every day, to try and prevent it. But nobody has thought about giving them some vaginal estrogen to try. And I've had a few patients where we've done that, and then they've been able to stop their antibiotics. And, we don't want people to be having to take antibiotics regularly. We want to be limiting antibiotic use as much as we can to prevent sort of resistance developing.
Yes.
And also they do have their own side effects, the antibiotics. They can affect sort of kidney function, and that there's lots of negatives to sort of going down that.
Yeah, I mean, they are needed, but if you get into that cycle of taking them again and again and again,
then that's where it's tricky. So, I mean, definitely, the development of antibiotics has hugely changed the human, population rate.
A lot of us wouldn't be here without them.
Exactly. And we want to make sure we've got them there for the future. So, if we can move away from using them in these sort of situations, then hopefully that contributes to us hopefully maintaining good antibiotic option for the future.
So you talked about vaginal estrogen. So I understand it's Vagifem that you can get from your GP, and then you can also buy it over the counter, can't you? It's quite safe now, isn't it? You don't need a prescription for it.
So I think it's I think you probably do need to have a slight chat with the pharmacist in order for them to sell it to you. But you can buy a version of estradiol 10 microgram tablets, and I think recently as well they've the cream preparation has become available as well that you can buy, but I think they are quite expensive to buy. I mean, obviously if that's the easiest way of getting them, then it's great, and I think opening it up to more women it's great, but it does make them it is quite an expensive way of doing it. And the vaginal products that should be available through your GP if it's something that you're struggling with. Vagifem is one example. I mean, I don't tend to prescribe that much these days. I tend to prescribe more of the sort of what we call estriol products, which have a slightly different type of estrogen in them. So Vagifem has estradiol, whereas there are some other products which have estriol in. And actually there's some evidence to suggest that they have a better affinity, so a better action in the vulvovaginal tissues. So I tend to use those, and they're actually considered to be ultra low dose, so really, really quite safe to use. And
they're a cream rather than
there's a few products. So there's a cream version. There is a gel version, which you use an insert with an applicator. And there is also a kind of a small pessary version as well. So there's a few different products that are available.
Great. And can you get those from your GP?
Yeah, definitely. In most places, I think they should be available. Very occasionally there are certain restrictions in formularies in different regions, so there is some slight difference as to what can be prescribed. But for most of the time, I think these are generally quite readily available.
Yeah. I do have some listeners in the States looking at my analytics. So, yeah, for anybody sort of overseas, it's really a product that is the estriol version of estrogen.
Yeah, I mean, you've got to find the one that's right for you. And some people will get on better with the estradiol versions. And, a case of trying a few different ones and seeing which one suits you better. There is another product available as well, which contains something called progesterone, which is kind of like a precursor to estrogen and testosterone. So this is, again, it's a pessary that you use. So it's slightly different, that it's not directly estrogen, but the body sort of converts it into estrogen and testosterone actually in the tissues. And so that can be another effective choice as well. That's a little bit newer, but I've used that for a few patients and they've found that helpful too.
Yeah, and I suppose it's, one size doesn't fit all. Yeah. I see that with women that come and see me, that they talk about their conversations with their doctors about HRT, and, some women just go and they get the sort of, 50 micrograms of estriol, like a patch or a gel, and they're absolutely fine with that. And other people go and they kind of start having symptoms, or they don't get on with the progesterone or whatever. And then if you've got a really kind of a doctor that leans in and actually takes the time to, personalise it for you as much as you can on the NHS, then women generally, it takes them a little while, maybe a few months, but they can find their sort of happy place where it's suiting them really well.
Yeah, definitely. I don't know
if you find that.
Yeah, I do. I mean, when I start someone on HRT, I'll take lots of factors into account as to kind of, what product I might go for. So, we have to think about their medical history. Are there certain reasons why we would use one product over another? Are there certain reasons why we might start at a certain dose versus another? So I try and tailor it as much as I can at the start to try and get us on the best, footing to get going with. But it doesn't always work. People don't always follow the textbook, sadly. So it does sometimes take a bit of tweaking. And sometimes I do have to change products quite often until we can find something that works for somebody. I try and encourage people to persevere if we can, because most of the time we can usually find something that will work for somebody. But you also have to make sure that you go into it with kind of realistic expectations as well. HRT is not the answer to every single problem. And I think often we kind of label a lot of issues as being related to menopause. And I think a lot of things are, there are 40 odd plus different symptoms that can be related to menopause. But I think it's also important to remember there are lots of other things that can influence how someone is experiencing certain symptoms as well. And I think that's another important thing, is about having realistic expectations. But at the same time, if someone is not getting better at all with something, then for me, that's a sign it's not working, and we need to look at sort of switching it and trying something different.
Yeah, okay. I would like to go on and talk about estrogen and testosterone and progesterone, the sort of sex hormones that we kind of start to decline in perimenopause. But first of all, do you think that HRT is a safe treatment for most of us? Obviously the headlines of the Women's Health Initiative, they do have a legacy, and a lot of women still, even with the information that's out there, very much have it fixed in their minds that if they take HRT, they are, increasing their risk of breast cancer.
Yeah, sure.
And, could you talk to us about that a little bit and what your thoughts are?
You're right. I mean, the Women's Health Initiative had a huge effect on this, and there was a dramatic decline in HRT prescribing around 2002, which is when it was published. And that lingered on for quite a long time, and it was only really probably around 2010, 2011, where things maybe started to change a little bit, and questions started to be asked about the validity of the data that was published and whether it was actually truly representative of the menopausal population, because actually it was quite skewed in kind of the ages of the women involved and the health issues that they already had. There's lots of factors that make it quite difficult to really take a huge amount of value from the results. But we are still sadly stuck with a lot of that data, and we kind of have to work with it. But what we would say, and I would say this is true, and this is what the guidance is from most of the menopause societies throughout the world, is that actually for the vast majority of women, the benefits of using HRT outweigh the risks, at least for the first 5 years of use. And unless there are some real strong reasons that we wouldn't want to use it, it should be offered as a choice. And I think this is where we need to try to do that more, because I think still in a lot of places it's maybe not the first thing that women are offered when they present with menopausal symptoms. Sadly, still women are offered things like antidepressant medications and things like that. But it's about giving women that choice, and particularly now with the kind of newer HRT preparations that we have, so the more body identical options, there's increasing data coming through about the safety, and particularly in terms of breast cancer risk for those sort of products, that show actually for the first 5 years of use the risk of breast cancer is essentially neutral for those products. There's less data on those, and there is that coming from kind of the Women's Health Initiative, so we're still kind of building that, but there is good evidence to support that now. So I think we can quite confidently say, particularly with the body identical options, that for the first 5 years definitely the benefits outweigh the risks for the vast majority of people.
Yeah, so some women are told to take it for 5 years and then to stop.
Yeah.
And other doctors will say, well, why would you do that? Because suddenly your risk of osteoporosis is going to increase, of, neurodegenerative diseases, heart disease, etc.
Yeah.
And they will say, well, you take it, until you're no longer standing.
Yeah. So traditionally we did have this 5-year kind of cut off, and that partly comes from the Women's Health Initiative, because that was kind of the benchmark that they were looking at, what happens at 5 years, and that's when it showed there was a small increased risk. So that's where this 5 years came from. But actually now, and this is again guidance from all the kind of menopause societies, is that we shouldn't have any arbitrary figure of the duration of use. We should weigh up someone's personal risks and benefits and make that decision ongoing. Someone should not just be told they have to stop it at 5 years just solely because they've reached 5 years. And there was some data published that compared women that were told to stop it at 5 years to women who were allowed to carry on. And those that were told to stop it for no other reason than they just reached 5 years showed an increased cardiovascular disease risk compared to the women that had been allowed to continue. The evidence now is that we should really be reviewing it yearly with women. So if you're on HRT and you're having it prescribed, you should be having a yearly review with whoever's prescribing it for you, so that they can chat to you about the pros and cons of staying on it in your individual situation, because that will be different for different women, and then making an ongoing decision. But there is no kind of rule that you must stop at 5 years. The difficulty is with this kind of attitude of taking it forever, is we just don't have enough evidence to know what risks that might come with, because we haven't got trials that have followed up women into their 90s taking it. So I think women should be allowed to make that choice if they feel that they're gaining benefit from it and they want to continue. But I think it's important that we do make them aware that we don't know whether there could be other risks involved. And the data from the WHI and the other trials does show the breast cancer risk does seem to continue to slowly increase the longer you stay on it for. So that risk does go up. We don't have as much data from the newer preparations, sort of following women up for kind of 10, 20 years. So it's tricky to say for certain with that particular type of HRT. But our assumption is actually that it's likely to be a lower risk than the older preparations, which were very sort of synthetic and
taken orally and passing through the liver.
Yeah, exactly. So it's a bit difficult to say to someone with confidence as to what the safety is of them taking it for 20 years right now. And the honest answer is we don't really know.
Yeah, no, fair enough. That's very honest. And it's just, I know myself, I've been taking, you start taking it, you think, I've been on it a year, I've been on it 2 years, 5 years, 6 years, and I'm probably like a lot of my friends and the people I see, once you start it and you feel, you've just got that extra something and you feel positive and stronger. Yeah, and you sleep better. I mean, there's so many benefits, once you get it right, that to suddenly say, I'm going to stop now.
Yeah.
Seems, yeah.
Yeah, and as time goes on, we'll have lots of women that have chosen to take it for longer, and that will, I guess, provide us with more information as to what happened. It's a sort of shame that women who are going through it now are kind of the trailblazers for kind of working out what's going
the
to
guinea
happen.
pigs. Yeah.
But I think it's about providing women with the information. So it's a bit like in my breast clinic. I provide women with the information that as much as we have, and then allowing them to sort of use that information and make a choice for themselves as to what they feel is best for them.
Yeah.
Right or wrong answer to that.
Okay. And I always think it's quite sad because, some women will come in and they've heard all these headlines that, it helps with your bones, it helps with reducing heart disease, dementia, etc. And they can't take it because, maybe they've got a family history of cancer or they've had cancer and they can't take it. What would you say to those women, because obviously women can age well, can't they, without HRT? And we have, not everybody that hasn't taken HRT in the past has, had crumbling bones and, withered away at sort of, 65. Some women have gone on to be quite strong.
Not to kind of over medicalize it and make it out as though if you're not taking this, then you're going to have all these health problems. Because actually, quite a lot of women will find that they won't have those problems. And if you're leading a healthy lifestyle and you're doing all those things to improve your health as much as you can, then that's going to make a huge difference. And I think one of the key things is looking at kind of body weight and the issues with obesity that we have, sadly, is a massive factor for significant health problems further down the line. So if you can tackle that, then that's going to make a huge difference. Things like alcohol use as well, minimising that. I'm not saying you have to stop drinking alcohol completely. I mean, some women do choose to because it actually aggravates their symptoms significantly. It's about doing things sensibly but recognising that there are lots of other things that you can do. And I think the opposite as well for women who are taking HRT, I don't think we should be letting them think that, well, if you're on HRT, then it means you can do all these unhealthy things.
Everything's just happening, yeah.
Because it won't do that either. So I think it's about sort of a balance of the two. But
yeah, and then there are some really good studies to show that, just weightlifting twice a week for like 30 minutes can really strengthen your bones.
Yeah, definitely. There are significant
making sure,
like
you've got calcium and vitamin D and, you're eating an adequate amount of protein and you've got sort of anti-inflammatory foods in your diet. So, diet and movement are huge, aren't they? Yeah, huge players.
Definitely. And, we should never, as part of our menopause consultations, that is something we should always be talking to the women about that we see. We shouldn't just be talking about the medical side, the medication side of things. And that's the approach that I try and take in the clinic that I run, is we do try and take a holistic approach. I mean, I'm not a personal trainer, I'm not a nutritionist like yourself, so I've got limitations on the exact guidance I can give people, but it is really important that we do direct them to that as well and make sure that they're approaching sort of every aspect of things as best they can.
Yeah, I totally agree. I mean, sometimes women will start taking HRT, but they're still having a glass of wine every night or two. They're not doing any exercise. Maybe they're overweight. Yeah. And they started taking the HRT and they've got a bit more energy. So it's a really good time to, start doing more exercise and using it that way, rather than just thinking, well, I can sleep now and, I don't have such low mood and I'm not having hot flushes. And so the HRT, that's it, tick.
Yeah, definitely.
Because you're obviously increasing your risk of breast cancer, aren't you? If you, if you're drinking every night.
Yeah. So if you drink more than 2 units of alcohol a day, that's more of a risk
factor for breast
cancer.
I mean, 2 units, that's, that's
within,
a small, very, very small glass.
It is, isn't it? I think especially now, when probably since COVID, we'll probably do more home measures of alcohol than maybe before. And 2 units is quite easy to have with one kind of glass of wine, really, depending on the strength that you have. If you had 2 units a day, that's 14 units a week. That is theoretically the kind of what is the upper limit of what's recommended. So it's not.
Yeah, it's not even and that's the upper limit for both men and women, which I always find a bit strange because obviously men are larger, they have bigger livers, they've got more tissue to absorb the alcohol. I've never really understood why they've made it, because it used to be, I don't know, was it 14 and 21?
Yeah. So, I mean, it's tricky, isn't it? And I think, to be honest, reducing alcohol is definitely a sensible thing to consider at this stage. And, looking at it and having it, if you're going to a special event or something, then I'm not saying never have a drink, but it's about just doing it in moderation but recognizing why you're doing that and the benefits that gives you, I think is really important.
Yeah, and sometimes there's a social pressure as well, isn't there, to drink, and you don't even want to drink, but you don't want to be appear to be really boring or not very sociable.
It's like if you didn't have a drink, it was like, oh, you can have some orange juice or lemonade or something, and it's like, oh, that sounds exciting. Whereas now,
actually, I did a podcast, I don't know if you heard it, but it was with the founder of Mother Root, which is this lovely ginger sort of spicy aperitif that you use a little shot and then you mix it with like ice and soda water and some orange, and oh my goodness, it's so delicious. Really, and that just feels like a significant drink rather than just drinking plain water or,
definitely.
fizzy water or...
I don't know about you as well, but I often find the glass you're drinking it out of makes a difference as well. So something in a nice fancy glass can often make it feel a lot more exciting.
Yeah, because I used to think, why, I really used to sort of fantasize about a glass of rosé and, that nice, really cold rosé in a, beautiful glass, and think, what is it about it? And it's not actually that it gives me, that sort of dopamine hit and you kind of get kind of relaxed with it. I think it's just more around the ritual of it.
Yeah, I think there's a big...
So I found that, the really good non-alcoholic drinks like Mother Root, which isn't particularly sweet, because another problem with some of the non-alcoholic drinks, they are quite sweet, aren't they? And they're probably not doing your blood sugar any favours. But again, making that more of a thing, and it feels quite special. So I wouldn't have it every night, but I often crave that more now than I do, a glass of wine. Yeah. And there are other occasions, like last night I was with friends and, this beautiful table and beautiful little glasses and a little bit of red wine in each glass. And I had a very small amount and it was just lovely. And it didn't, it didn't wake me up in the night. Like, if I have 2 glasses of wine, I guarantee I'll...
the experience of it. And...
and it didn't wake me up. So that's always good. I mean, anyone who listens to me must think, oh my God, we know about you, having 2 glasses of wine, Amanda, and waking up in the middle of the night. But it's like my liver's trying to clear it. And then, boom, I'm awake. Horrible. Can we go on to just talk about the various prescriptions of estrogen, progesterone and testosterone and why we might need all 3?
Yeah, so I mean, I do prescribe quite a lot of testosterone in the roles that I have, both in the NHS and privately. I think the challenge with testosterone at the moment is kind of limitations on the data that we have about it. And I was actually at the International Menopause Society conference in October, and there were quite a few talks about it there. And there is increasing amounts of data and there are trials happening. But at the moment, we don't really have a huge amount of evidence to support using it for lots of different things that maybe in social media it's kind of shown, talked about as though it helps with things like mood, helps with muscle strength, might help with cognitive function. The struggle at the moment is the limitations on the data to support that. There are little bits of data that do suggest these things, but there isn't enough to kind of bring it together to make it a reasonable kind of guidance that we would say, yes, this is a treatment that will do this and we can use it. The only factor where there is enough evidence to sort of say that is in terms of sort of low sexual desire. And so that's the reason at the moment that we're kind of limited in how we can prescribe it, and particularly in sort of NHS settings. So in my clinic, that's the reason really that I can prescribe it for women. It's tricky though, because I think in practice, and I'm sure a lot of my colleagues feel this as well, quite a lot of women do get benefit from testosterone, and we do see it benefiting in other ways. In fact, in my personal experience, I'd say a lot of the women I see maybe find less benefit in terms of kind of their libido or desire, and maybe more benefit in kind of energy levels and muscle strength. But that's just anecdotal, that's not, I don't have firm data to back that up. But hopefully, as time goes on in the not too distant future, because there are trials ongoing, that we maybe will have more evidence to support using it. I must say, I think in my own practice, it does seem to be a bit hit and miss as to how much benefit women get from it. So I've definitely had women who found it hugely beneficial, and it's definitely been the sort of bit that was missing for them. And we'd got them established on HRT first, which had made a huge difference to lots of things, but there was still some bits that were not quite sorted, and we added that in, and that made, was definitely the answer for them. But I've also had women who could almost have the same pattern of symptoms, and we've tried it and it hasn't worked for them. Maybe part of that is our knowledge of it, not really understanding the best way of using it for different women. Frustrations about the products that are available, because we don't have any licensed products in the UK for women. So we're having to use products that have been licensed for men in kind of a very haphazard sort of way, and I think sometimes that can be difficult for women to use it correctly. So there's a lot to learn, I think, around testosterone. And again, I think women of this generation at the moment are the ones that are pushing forward with hopefully getting us to know more about it.
Why do you think we still don't have it on licence in the UK? Because, the ovaries produce estrogen, progesterone, testosterone. So it is one of our hormones and, we do lose it, don't we, in menopause? Yeah. And we can replace estrogen and progesterone. Why can't we, have a product that's, suitable for women?
Yeah. My honest answer is I don't know the answer. I think there are multiple factors, probably financial reasons for companies that make it. I'd suspect that possibly will change, because obviously it is becoming more of a popular treatment. So I suspect a number of companies are going to kind of clock onto that and think, actually, this is something that women are wanting to use. So hopefully there will become products that become available. I think the difficulty is, I mean, I've never had to be involved in the licensing of a product, but I think it's a complex process and takes quite a long time. And I suspect maybe financial reasons come down to a lot of it. Which is frustrating. I mean, there is a product that is licensed for women in Australia.
I've heard about that. Yeah, what's it called?
So it's called Androfem.
Oh, yes.
So it's a cream preparation, comes in a tube, and you have to draw a little bit up each day. So it's still not perfect because you have to draw it up with this funny little syringe, and I think a lot of women get a bit fed up with the syringe. But I've got quite a few patients that have chosen to use that because they feel more confident that it's something that's been licensed for women. I mean, in my professional opinion, it's not really necessarily any different to the other products. It is a cream rather than a gel, but it's delivering the same treatment.
Different dose.
I mean, the dose theoretically should be fairly comparable.
Okay.
But I think some women just prefer to use it. And the problem is it's expensive, partly because it has to be imported, but also I think it is more expensive because it's been designed for women to use. That's my slight cynical view of that.
And the product that you use that's designed for men, what's that called?
So there's a few that you can use. I mean, the one that I most commonly use is called Testogel, which comes in a little sachet. So it's essentially a gel that contains testosterone. So it's not been designed specifically for men to use it as such, but it's been licensed for them. The tricky thing is men, if they have testosterone issues, they're going to use a much higher dose than a woman would use. So the products are just, the packaging is designed for them to deliver the dose they need, whereas women need about 1/10 of the dose, more or less. So actually it becomes quite tricky. So with the sachets, men would use maybe 1 or maybe even 2 sachets every day. The standard dose for a woman to use is using 1 sachet, but over about 8 days. So putting like a little bit of it on each day, which is not ideal. You know, with a sachet, like what do you do with it?
Sounds quite random, yeah. What dose you're going to get?
Yeah. It's not. You can't reliably give the same amount every day.
No.
There is another product, and there are a few products, but there's another one called Tostran, which comes in a pump bottle. So this is a bit more accurate in that it kind of gives you that set dose. But the problem is that dose is quite high, so it's not something that women can use every day. So the standard dose of that is that you'd use 1 pump of it every other day. And sometimes even kind of every 3rd day, depending on how well women respond to it. But I don't particularly like doing things like that because that's not a very natural way of giving somebody something that you get a peek of it and then you don't do it for a day and then you get another peek of it. And I think sometimes it's difficult to remember as well. I mean, did I do it yesterday? Did I not do it yesterday? Whereas using something daily, I think, is sometimes a bit easier. But the pump bottle is maybe easier for some women, so occasionally I do use that as well.
So could people get this on prescription in the UK?
You can. So things can be prescribed out of license. In fact, we do a lot of women's health things out of license. So a lot of contraception and things, the way we prescribe those now is all, again, we call it off-label, essentially. There are certain rules around prescribing off-label. So you have to be able to say that it's been shown to be an effective option and there isn't a suitable licensed available option. And so with testosterone there isn't. So that means that yes, it can be prescribed. Now it varies a little bit throughout the country as to whether you can get this within sort of the NHS though. So different localities have kind of their own formularies as to what medications they're happy to kind of offer as prescriptions, and testosterone is not always listed as an option. That is very much a sort of local decision. In some places they do accept it if it's been initiated by kind of a specialist. So where I work in Saffron Walden, I can initiate testosterone in my clinic there. And then we've kind of written a pathway to allow the local GPs, once I've established somebody on it, for them to take it over. It is tricky though for GPs because it's not a licensed product, and when you are prescribing something out of its license, you do have to be able to kind of justify why you've done it and feel confident that you've made that choice. And if they've not had training in how to prescribe it, or the risks and benefits of it. Because if you're prescribing it, you're putting your name on it and you're saying, I'm happy for you to have this treatment. If you don't know or can't talk to that patient about the risks and benefits, then you shouldn't be putting your name on that prescription, actually. But I feel like there needs to be at least options for those women. So if their local GP isn't able to do it, there at least should be someone that they can be referred to. So I think this is where, sadly, there's still work to be done in that. And that varies throughout the country a bit.
What I see in my practice and with my friends is that most people don't have testosterone unless they're seeing a private doctor and they're getting a compounded version from a from a pharmacy, and that prescription is made specifically for them, so it's very low dose. That and they're the only ones, and they're paying a lot of money for for that testosterone.
I mean, in my private clinic, I do prescribe the same products that I would prescribe on the NHS. So the Testogel and the less commonly Tostran, but I can't prescribe Androfem in my NHS clinic, but I can prescribe it in my private clinic. So there are these options out there. But I think it is quite varied at the moment throughout the UK.
Yeah, so someone really has to go and say to their, again, this is my understanding from what I've heard, but they have to go to their GP and say, I've got no sex drive. Can I please have some testosterone?
Yeah.
I mean, who's going to say that to their,
it's
maybe,
really
but it's
up, isn't it? And I think this is where the limitations on prescribing really comes from the evidence, and we can't do a huge amount about that at the moment until there is more evidence available. Because I guess we do have to be happy that we're prescribing something that isn't going to be harmful to somebody. I mean, really, actually, the data for testosterone is pretty reassuring in terms of safety. There are some side effects that it can give you. So, the common things being sort of greasiness of the skin, maybe getting a few kind of spot outbreaks, maybe some hair changes. Weight gain was seen in the studies as well, so I always make people aware of that. And then there's some rarer things that are not really seen at the dose that we need.
Do you think that weight gain, though, is because, testosterone helps build muscle, doesn't it? Do you think that's part of that, which would be a good thing, wouldn't it, to build more muscle, because most of us are losing it?
I mean, interestingly, in the trials, there's no suggestion that women stopped using it because they felt they'd gained too much weight. But I mean, that's what I often say to people, actually, is like, the weight gain could well be that you're converting fat, you're losing fat tissue and actually improving your muscle mass, which is going to be a bit heavier. So when you stand on the scales, it's going to look a little bit like you've gained a little bit of weight, but actually it's a positive weight gain rather than anything negative.
Yes.
But it's hard because I suspect in the trials that they didn't do like body composition assessments and things like that. So it's difficult to say for certain.
So we're kind of at the beginning of getting that data,
I think we
presumably.
are at the beginning of the road of that, really. And but it's interesting to follow how it goes, actually. Hopefully that is it's great that women are actually open to trying things as well,
Yeah. So really, if you feel you need testosterone and you're already taking estrogen and progesterone, it's a case of, it may give you more energy, it may improve your libido, your mood, potentially.
I think, I feel like it does have the potential to improve those things. But if you're talking strictly based on kind of what have we got enough evidence for, it's probably just in terms of kind of low sexual desire issues. And then that in itself is complex as well. So in someone who is suffering with that, again, it's about that kind of having realistic expectations as to what something is going to achieve as well, because sexual desire, libido, all of those things, they're very complex in women. It's not just about the level of testosterone in your body. It's about multiple other factors in your life. If you've got a hugely stressful job, you've got financial worries, your relationship isn't quite as good as it was, all of those things are going to impact how you feel around sex. And
it's not suddenly going to make you,
it's not going to massively change that.
Solve all your financial issues.
Yeah, exactly.
Make you fall in love again.
Yeah, and there's lots of, there's some really good speakers out there about kind of psychosexual issues and just the fact that actually naturally, as you get older, it's natural for kind of your sex drive to reduce. That is normal. And it's about recognising that as much as anything. You're not thinking there's something wrong with you because this is happening. The other thing that's quite interesting, which I heard, was about how one of the biggest reasons for kind of a drop in sexual desire is being in a long-term relationship. And that's, again, sort of considered to be normal. And it's about recognising that. And it might not always be about improving kind of your libido. it might be about other parts of your relationship as well that might be just as important to look at.
Yes, yeah. Everybody wants a quick fix, that's the thing. You wanna
Yeah,
rub a bit of
it
testosterone and
is,
be
isn't it?
ready to go,
Yeah,
you
yeah.
know?
And if there's lots of other things going on that are influencing why your sex drive is low, yeah, just giving you a tube of testosterone cream is not going to be the answer. One of the other key things though is sort of the vaginal issue as well. So we spoke earlier about sort of vaginal dryness and the impact that has and can make sex painful. One of the things I always try and do before looking at introducing testosterone is making sure that is not a major problem for somebody, because if we kind of do add in testosterone and sex remains painful, it's not going to be something that they're going to want to keep doing. So it's important that we do address that as well.
Yeah, that's a really good point. So if someone's considering taking body identical, which we know is the safest form of estrogen and progesterone, which brands would you recommend they take, or which ones are you
Yeah, I mean, to
prescribing?
be honest, there isn't a particular brand that I would say, oh, this is the best brand that you should be taking, because there are lots of different reasons why someone might choose one product over another. I mean, gel preparations have been traditionally quite popular, so that's to give you the estrogen, the estradiol part. I mean, my personal view of gel is that actually it sounds like a bit of a pain, having to put this on, waiting for it to dry. I always hear these stories of women kind of wandering around the house with their underwear on, waving their arms around and things, trying to wait for it to dry. I don't know about you, but my household on a morning, I don't think I've got, time for me doing that. But a lot of women do like it, and I think it's very personal. So I don't believe there's kind of one product that is better than another in terms of the estrogen. I think there's different reasons why women would choose different choices. One of the frustrations at the moment is kind of supply of products. Now, for a while, that hadn't been too much of a problem. A few years ago, we were having real serious issues with gel, and then real problems with Utrogestan. And I felt like every day I was having to deal with kind of managing somebody who was not able to get it, which was really difficult. And sadly, now we're back in a similar situation with Estradot patches, which is a very popular brand because they are quite nice, because they're quite small and they seem to stick very well. And so a lot of women do like
So
them.
these are patches that you put on your, your
Yes,
buttock or your leg.
exactly.
Yeah.
So they're estrogen patches and they come in various different strengths. But apart from the 25 microgram patches, of which there are still a few available, the other strengths are all currently not available at all. And it sounds like that's going to be an ongoing issue for at least the rest of this year. And for a lot of women, there are alternatives. There are different brands of patch we can swap to. And for most women, that's going to be fine. We can even
Yeah.
switch to a gel or a spray if needs be. But there are going to be a small number of women who have maybe tried multiple different products, and this is the only thing that has worked for them. And that's where it's going to be really challenging, and it's difficult. And I'm not sure that I even have the perfect answer in that sort of situation. Just hoping that the stock problem might resolve.
Estradiol is what I use, and the other patches are huge in
Yeah, the
comparison.
size is massive. The size difference is massive.
For me, it's definitely the size and the convenience,
Yeah,
and I think that's
yeah,
why it's become such a popular
yeah.
patch. And you change it twice a week, so it's kind of
Yeah,
really easy,
yeah.
isn't
So
it?
most of the patches are quite similar in kind of the frequency of how you change them, but like you
Yeah,
say, the size is massively different.
yeah.
But if it's just that element, I think for a lot of women they'll possibly be able to cope until the end of the year. I mean, it's not ideal. I mean, it's not great,
What
is
is
it?
the problem with supply then?
Yeah,
Do you
so
know?
I don't know the full ins and outs of it, but it's to do with kind of the manufacturing, which I think is partly done in America and where they're sourced from. I don't know the exact reasons, but that's where part of the problem is lying. Now, there's a
Okay.
plan, as far as I understand, for another factory to be kind of established in Europe. But obviously, that's not something that just instantly happens overnight.
Stop it overnight.
Yeah,
No.
so they're sort of suggesting that would massively increase production, but probably not until the end of next year. If they found that estradiol is the only option that they absorb through the skin, because that can sometimes be a problem. Because I've definitely had that with some patients where we've kind of used lots of different options through the skin and they don't seem to absorb it, but they do seem to absorb estradiol. Don't think we know why one product seems to be different in that way. But using an oral option is potentially an option as well for some people. But what I would say is if this is affecting you, you should go and speak to the person who's prescribing your HRT, and there are definitely ways around it. There are quite a lot of different products available, so for the vast majority of women, I think we would be able to find something that would suit them.
That's reassuring and great advice. And then just thinking about progesterone, Eutrogestan, which is what most people are prescribed, 100 milligrams nightly. I mean, I know some people are prescribed 200 milligrams, for 2 weeks and then have a break.
Yeah.
The majority of women I'm seeing is more like 100 milligrams, but everybody seems to be on the same dose. Yeah. And some women just do not get on with it at all. They feel quite low on it. They feel quite bloated, and it results in them coming off HRT altogether, or finding a different solution. Is that the only, because obviously compounding pharmacies can come up with progesterone cream and other solutions, but on the NHS it does only seem to be Eutrogestan that's available. I mean, do you prescribe anything else?
So in terms of progesterone, then Eutrogestan is probably the most commonly prescribed brand. There is another brand available now, which is called Jetprotix, which is, again, it's the same progesterone product in a little capsule. And like you say, most women will take one a day. If they're postmenopausal, that is usually what happens. If they're not bleeding anymore, if they're still having periods, that might be why they take it in this kind of 2 week on, 2 week off pattern, and the dose is slightly higher. The reason the dose is the same is because that's the dose that has been shown to protect the womb lining. So the reason we give people progesterone is to prevent them developing endometrial cancer. So we know that estrogen stimulates the womb lining to grow, and if that's allowed to just happen without any intervention, then there's an increased risk of cancer forming in that tissue. And what the progesterone does is it stops that. And so as part of the dosing is based on what evidence we have of the dose that's required to provide that protection. So for most doses of HRT, that is the dose of progesterone that they've said is adequate to provide it. When there's some new guidelines produced by the British Menopause Society last year to do with kind of bleeding problems, because one of the issues with progesterone, the natural sort of progesterone, is that it's slightly weaker at doing this job. It's still good, but for some women it doesn't always quite control bleeding, and so women have been having these kind of breakthrough bleeding problems, and that raises all these worries about, could that be because they're developing cancer, and they end up having to go and have all these investigations, which is really horrible. Yes. So there's guidance now on potentially using higher doses of progesterone when someone's on a very high dose of estrogen. And if you're worried about that, then I would say definitely speak to your prescriber. But essentially it means if you're on 100 patch or you're using 4 pumps of gel, that's the dose at which it's suggested we might need to increase the dose of progesterone, particularly if somebody's had any bleeding issue. But at the other end of the scale, sadly, there isn't any evidence that we can use a lower dose. So it is recommended that is the dose that we use. Now, sadly, some women really do struggle with progesterone, and I classically see it in patients who've maybe had issues with PMS, because that often is something to do with progesterone. But some women, it can affect their mood quite significantly. It can upset their bowels and cause a lot of bloating, nausea, that sort of thing. So in that situation, there's a few things we can consider. One option is we can off-label, again, use it vaginally. So instead of swallowing it, some women can use it as a vaginal pessary. And that's there's evidence to support using that. And the idea behind that is you get less in your system, less systemic absorption. It's not going through your bowel, so it minimises those side effects. And for some women that works well. The problem is,
and would you use that in the same way, like 100 milligrams a day?
The guidance is that we should keep the dose the same. So there are certain clinics, I think, that have advocated using a lower dose, but guidance from the British Menopause Society, for example, say that there isn't enough evidence to say that a lower dose is effective. And so, the reason we're doing it is to prevent cancer. So we have to be sensible and make sure we're doing that properly. But if somebody has really...
Can I just ask, Susie, when women do that, do they generally get on quite well with it?
Yeah, women that found that, definitely from terms of side effects, made a huge difference. The only negative is not everybody wants to do that. Swallowing a tablet is obviously a lot easier. And if you're already using a vaginal treatment for sort of estrogen, like an estrogen, then it's like, I've got to use this as well. And so it just adds a bit of a kind of slight difficulty to it. But it is an option. And if someone's really keen to have that, then that's great. We can do that. But if somebody is really struggling with the progesterone side effects, sometimes what I would suggest suggest in that situation is that we look at an alternative progestogen. So these are kind of synthetic versions of progesterone. Interestingly, some women will tolerate those better than they do the more natural progesterone, particularly those that have maybe had issues throughout their life where they've had cyclical mood problems, or they've always had a bit of an issue with progesterone. So some of the more synthetic versions can sometimes be used, and some women will tolerate that better. The other option is considering sort of a hormonal IUD, maybe another choice as well. So a coil that contains a type of progestogen. For some women, that can be a really good choice because there's less systemic absorption of that, but it's very, very effective at controlling the womb lining, and particularly women who are having a lot of bleeding problems in that perimenopause phase, that can be a really good choice for them.
Great. So lots of options there, really, if you don't get on with Nutrigestan
Yeah.
orally.
The tricky thing is you mentioned about progesterone cream, and the difficulty with that is there's not very good evidence about absorption of progesterone through the skin.
Yeah.
Because the reason we're using that is to protect your womb, protect you from developing cancer. This is where the concern comes with these compounded products, because there isn't actually that much regulation around them. And yes, using a more bespoke dose for a woman might make her feel better, but is it providing that protection for her? And that's the concern that we do have with the sort of compounding options. So as a British Menopause Society, a registered doctor, that's not a type of HRT that I would advocate using. It's personal choice, obviously, and I'm sure they are very effective because they're giving you pretty natural hormones, but it's just about the safety of them. And I think that's where, at the moment, where some of the sort of anxiety lies around those sort of products.
Yeah, I mean, it would be really good if women could have like a uterus scan, like once yearly, just to check their lining, which is something I do personally.
I mean, a while ago,
but it's getting more expensive as cost of living is going up. But
I think there are quite a few private services, and I have done this with a couple of patients previously where we have monitored them. I think the tricky thing is we don't have a lot of good guidance on how often you should do that, and at what cutoff do we then start to say, is there a problem, and actually is there enough evidence to say that that's an effective way of screening for cancer changes? There's lots of difficulty to that, but I have occasionally had some women where the only thing they can tolerate is, they can't tolerate anything. And then we make the decision to say, well, do you want to stay on something, and we'll monitor this. And very, very occasionally I've had some women that have chosen to do that.
Yeah, fair enough. So one last question, and this has been a brilliant session. I'm sure women are going to find this really useful. It's been so comprehensive. But just wanted to ask you about testing, because you were talking about some women don't absorb well and some people do. And how do you ascertain that? Because I have the impression you're not keen on sort of testing somebody's individual hormones and then prescribing on the back of that, which is what some private doctors do.
So it's a really, really challenging area, this, because, and actually weirdly, I was talking about this at another thing just earlier today. Is the guidance at the moment in terms of testing is that it's just really quite unreliable. So blood testing, particularly for estradiol levels, which is kind of often what we would be sort of questioning, should we be monitoring someone's blood level and use that as a way of monitoring their treatment? And at the moment, the testing options that we have don't really do that very, very well. And so you can do a blood test one day and interestingly, someone's taking the same dose product, even a patch actually, which you'd expect to give somebody a really constant dose. There's situations where someone will have a blood test one day and then another test the next day, and it's totally different. The blood levels are totally different, and so it's.
Is that even the case if someone's postmenopausal and their hormones have settled?
Yeah, so this was discussed at the British Menopause Society last year actually, because there is this kind of idea that, why can't we just do blood tests and monitor people? Because it makes sense that you should do that, because we do that with lots of other things. But at the moment, it just feels like the testing is just too unreliable, and there is no level that is kind of felt to be this is the level we should aim for. So the kind of blood level that you need might be very different to the blood level that I need. And I've seen that in women, definitely. The dose that somebody needs can be so varied. And so there's no consensus on what blood level we should be aiming for or what blood level is going to resolve somebody's symptoms. There seems to be huge variability in the actual testing. So whether the testing itself is just not accurate enough, the type of tests that are being used, and also whether the blood level actually reflects what's actually going on a cellular level. And that might not be the case. And the way in which estrogen is metabolized is so complex that actually just measuring estradiol levels really isn't hugely helpful. So for a while we were sort of saying, oh, we could do it to give us an idea. Most of the time now I think it causes more questions than answers. The only time I maybe do think about it is if I've got someone who is using quite a high dose of estrogen through their skin. So maybe we've built up to a patch of 100 and they don't seem to be kind of responding quite as I'd expect. Then sometimes I might consider checking a level at that stage, more to just see, is their level really low, which kind of would suggest to me that they're not really absorbing that treatment, and it just gives us a bit more of a guide. But it's more about we should be monitoring someone based on how they're feeling, how they're responding, rather than what a blood level shows. And I think that's the situation we're in right now. Whether in the future, testing will improve.
Yeah, it might change.
Yeah, because you'd like to think there is a more scientific way of monitoring this, because I do find it quite challenging sometimes when I talk to someone about this, because when I'm saying it out loud, it sort of sounds like, well, that sounds stupid. Why can't we?
Yeah,
why can't we do this?
I mean, there are private tests like the Dutch test. I don't know if you've heard of the dried urine.
Yeah, so I have, and I've had patients occasionally send me reports of these tests, and the thing is, again, it's about how do we actually interpret that information? And I think that's where it becomes really difficult, because they haven't been formally kind of validated as an actual way of us formally assessing somebody. So it's really difficult for me to look at someone's results and actually make some sort of meaningful interpretation from them. And I think that's where the difficulty is at the moment. So I'm not kind of against them in the sense that they're not doing what they're marketing themselves as this and they're not doing that, because actually I think they have gone through lots of approvals of saying this is a potentially fairly accurate way of checking these things. But it's about how do we use that information and actually interpret that to help guide someone's treatment. And I think that's where it becomes, we don't have the answer to that right now.
And these tests aren't, they're not under the NHS umbrella, are they?
Yeah. And, what if we see a certain level, what does that mean? Does it mean that we need to increase that person's dose? Well, what if that level looks low on that piece of paper, but that person actually feels really well? Do we then change it based on that? There's no guidance on how we respond to those results. So that's where the problem lies at the moment. It's the same with sort of testosterone. I mean, testosterone is one of the situations where we are recommended to do a blood test, but that's more from kind of a safety perspective, so that we're making sure that we're not kind of giving somebody testosterone if their blood level is already at the top end of what is considered to be sort of female range. But that's a bit of an argument, because there's been no formal actual clarification as to what is considered normal for a woman. That has not been formally agreed. So yes, you get these ranges from labs. They vary from lab to lab because there is no actual formal kind of level. And so what is normal for someone? The honest answer is we don't actually know that answer.
No.
So at the moment, the sort of guidance, this isn't strict guidance, it's more of kind of what is felt to be the best approach. It's kind of, doing a test, make sure someone doesn't have the level at the top end of things. And then my usual approach, and this comes from some of the information that was shared at the International Menopause Society conference, is that when someone's on testosterone, we do then monitor it initially and then sort of yearly, and we want to make sure that we're not sending their level too high, and that's considered to be no higher than 50% above the upper limit of the lab reference range. But that's not an exact guidance that's exactly what it should be. That's based on sort of consensus from kind of expert opinion, really. So there's a lot of room to...
It's quite a long way to go, really, in terms of testing and getting that day. So kind of trial and error. But that's where people like you come in, and, obviously you can guide people.
Yeah, and it is a bit more of trying to guide rather than being able to say this is exactly what we need to do. It's more of an art than a science at the moment.
Yeah, oh, brilliant. Well, thank you so much, Susie, because it's now 6:30. Susie's probably been working all day, and now she's doing this podcast at 6:30 at night. Before I let you go, can I just ask you, is there any advice for anyone listening, a couple of standout pieces of advice, as for midlife women that might be just looking for a little nugget of wisdom around whether or not they should continue taking HRT or taking HRT that
Yeah,
you
sure.
could give
I
them?
think a couple of the key things I often think about, and from kind of my experience of supporting women through this, is one of the things is that never to be kind of set back by someone saying you're too young to be experiencing these symptoms, because I do hear that quite often, and I do get quite frustrated, particularly when actually, this is sometimes to women in their 40s are being told this. We know that perimenopause can start a good 10 years before menopause in some women, and the average age of menopause is 51. So if we're saying perimenopause could start 10 years before, that's going to be 41. But actually, menopause itself is considered normal from 45. So if we're saying 10 years before that, in someone's late 30s, they can be experiencing symptoms. So it's one of the frustrating things I find is women being told they're too young. And sadly, 4 women in every 100 will actually go through menopause under the age of 40. So it does happen in younger people. Now, I'm not saying there might not be other reasons why women can experience symptoms when they're younger, but it's always that kind of, we shouldn't just, cross it out as an option just based on someone's age. So that's one key thing. And the other thing is, I think in women's health just generally, is don't feel that you just have to put up with your symptoms. So symptoms, women are very good at that, I think. And often by the time I see women, they've been struggling for a long time, sometimes years before I actually meet them. And so for me, it's like, if you're having symptoms that are impacting on you being able to live your life the way you want to, then talk to someone about them, because actually there are usually things that we can do to help. And I think we're all too good at looking after everybody else and maybe not ourselves. And actually, if you focus on yourself and get those things sorted, often you can then look after other people so much better as well.
Yeah,
Looking
that's
after
so
yourself
true.
first. Yeah, not putting up with symptoms that are impacting on you. And I think this stems as well, not just to menopause, but, with period problems as well. The number of times I've met women struggling with awful periods, and they've been like that for years, and they've just kind of put up with it. That would be the other key thing, I think.
Brilliant. That's a great note to end on. And if people want to find you, your clinic is online, isn't it? Your private clinic.
So it's called Cambridge Women's Health. So I started it in 2020, just before COVID. So originally I was doing it face to face, and then COVID happened, so we went online, and we've kind of remained online because actually I think it lends itself really well to menopause consultations, and it means I can kind of meet women from anywhere in the UK. And so you can book an appointment directly through the website. You don't need to be referred by your GP. Once you've booked, it does ask you to fill in a questionnaire. And I do kind of encourage people to provide as much information as possible, because that makes it easier for us to support you and ask what you actually want to get out of the appointment. And then we provide a report for you to take away. We can prescribe HRT for you as well, including testosterone products. And then you can either carry on following up with us, or you can decide to go back to your GP. So I'm saying us because it was originally just me, but I do have another doctor that works with me now called Dr. Catherine Mellenby. So she's another British Menopause Society registered specialist. 2 of us now, so we've got a bit more opportunity for people to have appointments. And so far we've actually seen about 750 women through since I started. It's been really, really exciting, and we just celebrated our 5th birthday in January. So
wow, congratulations.
Good.
Yeah, brilliant. Okay. Well, thank you very much.
No problem.
And
it was nice to talk to you.
Yeah, have a lovely evening.
Yeah, you too. Nice to speak to you.
So that was a really interesting conversation around HRT and its benefits and risks, perhaps. And I hope it's given you a bit more in-depth knowledge so you can make your own mind up. I will put Susie's contact details in the show notes should you wish to contact her. And remember, her clinic is online, so wherever you are, you can speak to Susie and make an appointment with her. And we'll keep the conversation going about HRT because it is quite complex and it is changing. But I think at the moment it's good just to empower ourselves with knowledge and make sure that we're making the right decision for ourselves, whether to take it or whether not to. Anyway, I shall see you next time. Have a brilliant week and do keep listening. Okay, bye. If you'd like to find out more about my approach, you can find me and lots of my simple, nutritious recipes demonstrated on Instagram at Amanda Ryder Nutrition, and that's Ryder with a Y. Or you can visit my website, www.amandaryder.co.uk. Or if you like a copy of my book, Feel Good for Menopause, you can find that on Amazon. And of course, if you enjoyed this episode, I would really appreciate it if you could like, follow, or click the subscribe button. It will really help me grow the podcast and keep me going. So thank you. And of course, do get in touch. I'd always love to hear from you. So that leaves me to say I'm sending lots of love and light from my midlife goddess to yours. See you next week. Bye for now.